Okay, let's jump in. Hi, everyone. Thanks for joining. I know we'll have more people join us as we get through the next few minutes, but we'll just stay on time and make sure we're definitely done by 7, if not a little bit before. Clay Angel Hospital Medicine, we started this series earlier in the year. We had a first part on access, and we had three great speakers that talked about different places where they sit in the county and how they perceived access issues and tips and tricks and wins, which we'll get from this group as well. So I just want to start right off with Dr. Jeannine Rodems, and I'm going to have folks self-introduce a little bit about who they are and what they're going to talk about, and then just jump right in. 10 minutes for each, and then a Q&A for 10 minutes after for each one, and then we'll have a Q&A at the end. So Jeannine, welcome.
Thank you. It's good to have a discussion about this topic because you've got me who've been working in direct care for about 10 years now, and you've also got one of the leaders of the direct specialty care movement, Dr. Nguyen, who's going to speak a little bit after me. And both of us work at the state and even some at the national level, which has been a lot of fun seeing this movement go forward. I've a family physician. I've been in the community for a number of years. I've been in a variety of leadership positions from chair of family medicine at Dominican to on the board at the CAFP to our local medical society association as president and on the board continuing. Um, and right now, we actually have started a DPC coalition in this state that is helping at the federal level to work on some legislation to make it easier for a broader expansion of the model for at the state level and for some of the wraparound projects that are developing across the country. So it's been fun to be a part of this movement. We have been in DPC, direct primary care we finished our 10th year in February. We grew it from scratch. One of the first DPCs in our area at the time. We now have several that are here. There's a new one. I don't know if Blair is going to be on the line tonight, but um,
Oh, Jackie's actually on for Blair, Jackie Flores,
oh yeah. They're
or
both
with
going.
with Blair. Yeah,
I saw it.
not for Blair. Thank you for joining,
Like
Jackie.
they're both opening it looked like from their website starting April 1st. So they'll be in Monterey. There's a smattering over the hill from the East Bay down through the South Bay and up to San Francisco. So the movement is really growing. Direct primary care is a model where you totally cut yourself off from billing through the insurance world. And when you do that, several things happen. The first is that you're no longer sort of dictated to E&M coding, getting to level 4, clicking boxes, getting to level 5, trying to justify your work to the insurer rather than focusing on care for the patient. Um, the other things that it provides is once you've got a lot of that out of your way, then you have longer appointments for your patients. So we have 30 to 60-minute appointments for our people. We have far better access. We can get patients in within a couple days. We have some urgent spots that we keep as well for things that really need to be seen right away. We actually still do our hospital work in our models. So we are still admitting patients, adult patients. We don't do peds or OB at this point. But there are some DPC practices who are in more rural areas who are doing all of that work. They're able to do full spectrum family medicine care and they really enjoy it. When you move into this model and you eliminate that insurance component, the business model actually improves. So you bring your overhead down because you no longer have a biller and a coder and all of these support staff that are trying to continue to help you to get your reimbursement. You wind up with a business model that actually sustains itself really well once it's to your target and your patient population numbers where, for example, through the pandemic, people who were in the fee-for-service system were dependent on people being seen, physical body in the office. We aren't dependent on that. We can do medicine through a texting platform, through video. We had that in place before the pandemic started. And we saw overall 9 to 10% growth each year of the pandemic, not a loss like most private practices saw. Um, the ability to have that first access um, and you can imagine it automatically reduces the expense if you've got the time, if you've got the continuity, if you've got the ability of patients to see you right away. Um, the model has shown across the country over this last decade through a variety um, of studies that we reduce emergency room visits by anywhere from 30 to 50%, reduce hospitalization by 25%, reduce specialty referral by that same bracket, 30 to 50%, advanced radiology, things that would require, things that we can do that are monitoring or managing patients without having to go to the next level of care because we have that time and the continuity of care available. So we can have a comprehensive, good relationships with patients. We satisfy the quadruple aim as a model of care. And doctors who are coming to the model are loving medicine again because they are able to practice to their full scope of their training, have the time and the commitment to do that in a model that is what we perceive from the DPC world as a low-cost model that's different than the concierge model that still deals with higher prices and as a part of the fee-for-service, um, still practice in the fee-for-service system. Um, we're now also beginning to see, in just starting this year, there was some legislation that we had worked on for the last decade as well. Um, that did get stuck into HR1 that had bipartisan support that actually allowed rules over the HSA to be allowed as a payment for our model as well. So that has now opened an employer base that's going on kind of as we speak, spinning up. We are getting a lot of little local businesses that are connecting into these wraparound products that are trying to establish care with a DPC. Um, so we are seeing kind of that phase of growth where previously we'd been fairly organic with more of a retail model, but now we're beginning to see the employer model pick up because they've seen the 20 to 30 the overall reduction in cost is a 20 to 30% reduction that has been noted, and then they're seeing in those areas where there is access to DPC as a part of their platforms. Um, improved less sick days, improved employee satisfaction, improved productivity when the model is offered. So we're beginning to see, we call it the hockey stick part of what we've been doing for the last decade. Um, I'm at 10 minutes. I can keep talking forever. So
You've got
there's,
2 more minutes. We started late. You can go for.
okay.
I got you on a
Um,
timer.
okay, good. I'll go a little bit in the history because I've been in a variety of models from in the fee-for-service world, from private practice to large group models. And I saw this model in about 2013, very early in the movement. I think when we went on to the mapper, there were only that you'll see there's a thing called the DPC mapper, Frontier Mapper, that has kind of not all the way up to date information, but does show you pure DPCs, hybrid DPCs, business-based and specialty care DPCs across the country. And we were in that first 400 bracket when we started. It took me about a year to really say, is this really doable? I mean, cutting off all of what you've known as an insurance base for, most of your practicing life is a leap of faith that is very difficult for physicians to do. Um, and once I was able, after that year, to kind of convince myself that I could go ahead and do this, I finally just said, okay, I was also at that point in my career where it's like, I don't see this lasting much longer if I have to work like this. I'm not going to survive here. And I have to kind of do something to either lessen the load, step back, go find something else to do, or try this model of care. And I have to say, since we've left it, we enjoy what we're doing. We will never go back to a fee-for-service model, even if the whole thing failed for some reason. But at this point, it's thriving and doing great. So that's some of the history.
Oh, I love that. I remember when we first met 4 or 5 years ago, it took me a while to understand, and it was like a shift. You're doing what? You don't bill insurance. And so I just loved learning more, and every time I hear you speak, I learn more. So that's great. So 10 minutes, thank you very much. So we're going to open it up to questions for 10 minutes. This is what this forum is meant to be. So Q&As for Jeannine. Otherwise, I have a couple moderator questions.
Hi, Jeannine. This is John Christensen. Can you hear me?
Yeah. Yeah.
So, I've followed you, through this process really from almost day one. And I remember like a year after it rolled out, I'm trying to remember which major entity. It was probably a United Healthcare subsidiary jumped in and tried to grab at least one of the several reins. Um, so because private equity is ubiquitous at this point, what's happening?
Um, so in terms of what we're seeing right now, we are seeing because this movement is becoming popular, there are things like in Orange County, we have a cohort, there's a bigger cohort in Orange County. They're having big systems come out and say, we now have a
Mm,
DPC. You can join. But there's several issues there. It's not fee for service. It's got a very high price point. And the physicians don't have the autonomy. They're still sort of stuck in this semi world of, metrics and click boxes and referrals and that sort of thing that isn't really the true spirit of DPC. We are getting a lot of private equity. I've been cornered on floors of, I mean, I had this one guy chase me down. I was at the HINT conference and he just followed me. He says, "Are you sure you don't need capital? Are you sure? 100%. You can just fund, we'll just take it over. You can do everything and we'll just put the money in and we'll take over. And it's
mm,
like, no, I don't. We're thriving. We're good. So they
that's
come out of
awesome.
the woodwork. They've been coming out of the woodwork for a number of years now.
Amazing. Great question, John. Amy, your hands up.
Yeah, my question is, um, what is the panel size for like family medicine doctor doing DPC? And then for being available to your patients, do you partner up with the other clinicians doing DPC for call coverage and such?
Yeah, so right now there are three of us in the practice. Adam and I were the ones who started, Adam Yarme and I started the practice, and in August of 2024 we brought in Neil Palikirthy, who is our third doc. And I have to say our model, because we're still doing hospital work, is not something that it's more rural areas that have access to the hospital that actually do it. I think Adam and I still had the legacy of being on staff to be able to just transition into that with a commitment to continuity of care. And we've been able to keep it up. I mean, some DPCs wind up losing that. They don't have a volume. We're finding here that our volume is mostly Medicare. I have almost 50% Medicare in my specific practice. The practice overall is at about 43%. Adam has a very balanced family medicine practice, and Neil's bringing in an adult practice because he's an internist. So we'll probably skew a little bit higher with the Medicare population. Right now, the target numbers in general for DPC are 500 to 700 patients per doc. There's a few that go up to 1,000. Sometimes prime peds goes up to 1,000. Um, but you kind of figure out, I kind of say go to 500. It's a 4-day work week in my office. Some docs have a 5-day work week. Um, and get to the point where there's about the work-life balance part is important so that you're not, finishing your day and having another 2 to 3 hours afterwards of answering phone calls, emails, and all of that. So I know Adam got up to a point at one point we were during the pandemic, we were growing and it was like, wow. And we kind of just let it go. And he got up to somewhere like 560, 570 and felt like that was too much work. Brought it back down to about 550. He's sitting around 530, 550. I have a 300, I target about 300 because I'm running the business. So I have a 3-day work week and then 1 day business. And my other day is my supposed day off, which when you own a business, it isn't. Um,
Awesome.
and Neil will target about 500, I think, is where he'll be. But the model has a lower population. Um, you have to balance the number of patients you have for your access, because once you get too far out, then you're scheduling out another week. We usually have accessibility the following week. Me coming back from vacation, it packs up around your vacations, as you all know. But then, usually the week of will fill up the following week is very open. So we
Okay.
don't have impacted schedules. We have a smaller patient population for them.
Awesome. I see a question from Dan. Dan, are you able to come off mute and ask your question?
Oh, I
It,
see Dan's question, the
yeah.
procedural in this model, um, average income shift. So I mean, we are at target with a full practice for the primary care doctors and comparable to what they're being paid in the large groups right now. Um, but you do have to grow it. So, depending on when a new doc comes in, I always have the discussion. Is this something you really want to wade through the growth, or do I need to backfill you and help you get there? Usually it's like one or first or second year salary, kind of very low cost loan that you pay out, for the future. Um, but Neil, I think many of you know Neil. His wife is a physician as well, so she's working and he's doing this and growing really, really well in terms of um, how things go in the model. The procedural side of it, T can talk a little bit about that. There are situations in DPC where people locally in the community um, uh, negotiate individually with specialists to say, hey, can I get my patient to have a $700 colonoscopy from you? You have some cash-based negotiation. We haven't gotten into that level at this point. We sort of try to work on getting people to the specialists that feel comfortable with. We know some of our like T, if somebody's interested in going cash based, I send patients to her. So we sort of try to pull a network together with the specialists that we like to use. And sometimes that's successful and sometimes it's not because of the insurance status. So there's a lot of kind of fudging that goes on. But in some areas of the model, they've done the negotiations locally in small communities where they can cash-based price it and that helps the patient.
Fascinating. That's great. That's awesome to hear. How do you market? How do you market? How do you get the word out there?
It's one of these things that in direct care you can try all kinds of stuff. You can get your social media going. You can I think we dabbled a little bit early on, a little bit of an ad in the paper. We did one of those sort of local vanity rags for a community. Most of that does not pay off. The only thing I've found some traction with and that we feel comfortable using is the KAZU ads where you're helping public radio. They do you're an underwriter. It's not really an ad. And people are driving, other doctors hear about what's going on and, hey, I hear on the radio you're doing this and having more questions. But in general, it's the care you give. And we say it over and
Mhm.
over and over. 80% is the care you give to your patients that brings them in. And again, this business as a regular business grows like a regular business. It's not an insurance model where they dump 1,000 patients in your lap.
Mm,
It's like a 2, 3, 4 year growth phase that you have to go through to get, where you're covering your overhead and then you're covering your salary. And once you get to that sustainability level, it's like takes off on its own. It's doing great. So.
awesome. That's really informative. That was a great discussion. Anything else? Oh, John, did you have another question? And then we'll move on to Dr. Nguyen.
I had to ask this question, of course, Jeannine. So, practice valuations, how would you value the practice? And assuming there's no bricks and mortar, so how would you value the goodwill and have the valuation analyst tackle that? Um,
It's a good question. Part of me is thinking about this a little bit for the long term, how do you do a long-term transition at some point? Um, that's a good question. I mean, we basically, the goodwill it's the patient population that we have, the physicians, and their continuity and relationships with patients. It's not, how much are you billing on the site? It's how much is your insurance overhead? What's your, our 90 day is super, super low. It's like less than 1% at the moment. So, it's tough to value with the relationships and such. Um, and I've been beginning to think about that. How do you do that in this model? And it's while there are some assets in terms of physical structures, um, because we are actually in the middle of doing a new build out. So we are going to put a lot of money into a doubling of our space that's hopefully will be done in August. Where right now signed the lease before I went to Dublin. Um, We've got the architect has done the plans. He's submitting hopefully on Friday to the city, and then we have the sort of wait period for comments and permits. Um, so we are putting a substantial investment in that in order to grow, but the model is doing so well right now. While it's tough to recruit physicians anywhere, and we're a little different in this model with doing the hospital work. I think we'll be able to get the new space will be able to accommodate 5 to 6. We could push it to 7 physicians if we needed.
That's
The
great.
typical way, I don't want to take up too much time, but the typical
Got to
way
get me
this is
off
done
track,
is
John.
capitalization of assets or capitalization of income. You've
Right,
got such personal relationships. That's why I asked the question, that there is no fungibility with this economically.
right,
So it becomes an interesting proposition. We can obviously talk offline. But because private equity has reared its head so quickly, it's an issue because you're going to have to value it and come up with a methodology.
right.
Um,
Great question. Thanks, John. And we have time at the end. I just want to keep on close to the track of the um, 20 minutes per chunk here. And then at the end, I want to save a few minutes for Dr. Flores to comment on her practice with Dr. Cushing as well. So, Dr. Nguyen, it's great to see you on here. It's been a long time since we've worked together and talked. So you want to introduce yourself and talk about your where you sit with DPC specialty?
Yeah, thanks so much for having me here. Jeannine invited me on here, which has been really cool because it's not often I get to speak in front of other doctors because most doctors like their situation. They like getting paid every 2 weeks. They like having other people take care of the patients on the schedule, the marketing, the talking about money. Like there's different departments for all of these things, right? I mean, I was there. I'm fellowship trained in wound surgery. I love limb preservation, preventive care. I also really love surgery. And so I was at a conflict for a while. I had initially moved here about 10 years ago, working for the foot doctors, and that gave me the foundation of what a business is like, a private practice for podiatrists. And then I got pregnant, and then, I was like, how do I actually control my schedule? I can't do that working for somebody else in that model. And so I decided to branch off. I opened my practice in 2018, did what everybody told me to do. I took all of the insurances and I thought I was a hero. And then a year in, my bills were not being paid and I could not figure out how to pay my staff. And I was afraid to let them go because, when you get checks in the mail at like 10 cents for all the work that you do, it's a little insulting. And logistically, how do you keep the doors open? So it was either, I quit the job, shut it down, go bankrupt, or I try something else. One last thing. My one last thing was to leave insurance behind and see how I can do it as a podiatrist. There wasn't a lot of resources at the time, so I leaned on a lot to direct primary care to understand what it means to cut ties with insurance. But I had to do it for specialty care because I don't have longevity care the way primary care has it. I have episodic, it's procedural, it's surgical, you need an ingrown nail done, I can do that in a visit. We don't need to stretch this for 10 years. So I had to really think around the problems we have here in Santa Cruz County that would make me fit in this jigsaw puzzle of healthcare. I don't claim to say that direct care for podiatrists or specialty can solve all of the problems that we experience, but it can solve one problem. And the biggest problem I had seen in my private practice was that patients were not able to be seen on time, or the visits were really short. They had no idea what the cost of things were. So even though we would order all the stuff, we don't know if they didn't follow up because of the cost of their care. We don't know the insurance contracts they have. They're so individualized, right? And also, when patients came to me, it was late stage. They had gangrene. They had to be in the ER, and then they were referred after the fact. And so when I when I did so many amputations and after amputations, like, yeah, I love it as a surgeon, but like on a human to human level, that's not fun. That's not fun to tell a patient you came too late. And I struggled with that deeply. And I was like, how can we capture these people sooner? And you can't do that when the insurance-based model is really intended to deal with the symptoms that arise late on. So then I had to recreate some of the models and offer preventive long-term care. So the way that I run my practice, I have multiple options. You have the pay per visit. We don't say fee for service because I guess that's a bad word in direct care, but nonetheless, you come as, you need me, you come pay for the visit, no big deal, right? It's easy. And then I have longevity care where patients who literally cannot bend over to reach their feet to look at it, to take care of themselves, elderly, for example, they come see me on a month-to-month basis. And I've had patients who have been with me since the beginning, 8 years in my practice. And I see them every single month. And it feels like I've just known them all my life. We talk about senseless things, we talk about serious things, and it's really joyful to have that level of consistency in my practice. And then I have more packaged services. So, Dan, you were talking about how can this work for a proceduralist? If you provide a surgical option for people, you can either work with the surgery center or you can get creative and learn additional skills that can bring those surgeries that typically end up in ambulatory centers and bring it in-house, which is something that I could do as a podiatrist. So instead of having, the transition between let's do the surgery, let's plan it with the surgery center, let's go back and forth with insurance coverage. Instead, I brought all of the complicated stuff back home. So I can do elective surgery under local anesthesia in the office that makes that experience a lot more seamless. So things that I can do in the office are minimally invasive surgeries, like for bunion, hammer toe, non-healing diabetic foot ulcers that require a bone cut, for example, or a tendon release. Those are things that are now available in-house. And luckily for my specialty, we are moving towards minimally invasive options. And other specialties, they have some variation of that where you pick a few things you want to do, you leverage that, you create income in that, and then you become known for that. And that becomes a marketing and communication skill. So there's a lot of different layers to know once you unplug from the system that you didn't realize you kind of just had handed to you. And the thing is, it's really easy to learn on the fly. And so I teach doctors, specialists how to do this very concisely. And just like what Jeannine says, it takes time. Give yourself grace, give yourself 2 to 5 years to really understand the stuff that we didn't get to learn because somebody else did it for us. But, doctors are the smartest people I know. We can do hard stuff. And when we step back and we simplify, that's even harder for us. And that's the biggest challenge I see with doctors who think things should be complicated in order to earn the reward. But honestly, if you just unplug everybody from between you and the patient, life gets easier, you can scale faster, and you can have a life with your family. And that was the most important thing for me in this direct care model. So I don't know where we are in regards of time, Clay, but I
Oh,
can talk a
you have
lot.
three or
I
four
have
minutes.
I have like 4 years worth of podcast materials
Oh,
helping
wow.
specialists understand how to think and behave like a direct care doctor. And it really just comes down to, are you willing to learn some new skills? That's all it is. If you're not, if your life is too busy, if you don't have the bandwidth, don't do this. But if you feel like you want something more, there's a calling for you, you know that you can do better. You have a specialty that is very unique. You can monetize that. You can leverage that. And you can help fulfill the need that's in this community where people are waiting months to see a
Mm.
specialist. Or they see the specialist, and the specialist spends 3 minutes with them, 7 minutes with them. The patient leaves confused, frustrated, and they go straight to their phone and they're seeking answers on a Facebook group chat.
Mhm.
Like, how awful is it for people who have access, but they don't actually get what they need? And they're paying a ton of money into their premiums, their copays, their deductibles, all for what? For someone else to get rich? That seems kind of silly, right? So ultimately, for me, it ended up being an ethical question. Do I really want to participate in this system? Or can I break free and not only make money, but have time freedom and creative freedom to really enjoy medicine, not just hustle for the rest of my career until I retire?
Love that. So you have podcasts enough? Anything you can drop in the chat from like YouTube's or other ways to find your material?
Yeah, I can drop it in the chat.
I
Happy
have
to
so many
answer
questions, but
that.
I don't want to hog your time together. I'm going to definitely have to have another session. I'm sure there's questions, folks on the call. I'm curious how our educators are hearing all this from all the different things that you're hearing. Oh, great, thanks, T. We have
Yeah,
Tim and John.
everything's there.
Okay, John, you get you get one. Go for it.
Yes. Hi, simple question. Is there a professional, nonprofit that is forming around um, this type of podiatry practice yet? Or are you, because you really, or is there an arm within your professional organization, whatever it might be called? There's probably more than one.
There's a direct specialty care alliance.org that is
Okay.
all specialty included. It's such a small field that we're in right now that we need everybody to be together and just learn and innovate with one another. I don't think there is one specifically for podiatry. There are other like versions of it. We've got like regenerative medicine has their own entity. Functional medicine doctors have their own, groups, groupies and things. But for free nonprofit things, I would start with the dscalliance.org.
Great. T, how's it work with labs for both you and Janine? Like, what's the situation with how the patients are billed
They
for labs?
They always have two options. They have the option of going through their insurance. I tell the patients, go through your insurance, see if it's covered, tell me what the price is, and if I can match it with direct pricing, then I tell them the option. So an example of that is I go through altalabs.com and the only labs I really order as a podiatrist are like liver enzymes, AST and ALT. So if they don't have it, they can purchase that for like $17, $19. I don't know what it is.
Oh,
And then they can use their insurance and if it's fully covered, like it doesn't matter to me because we don't get kickbacks or anything. It's just a matter of what's convenient for the patient.
that's great. Oh, there's the timer. We have, yeah, I'm just going 10 minutes. We're so good on questions, so that's really helpful. Thank you. Other questions for Dr. Lynn?
So, um, thanks a lot for that, Dr. Nguyen. Since Clay asked the question, what do the educators think? I'll jump in. I've had Jeannine up to campus several times to talk to students about the direct primary care model, and I think it's pretty intriguing for them. And uh, I had no conception that you can do that with specialty care too. So I really appreciate that. The other thing I'll add on is that my son's in Jeannine's practice, and from the patient side of thing, it's super easy and seamless, and we've been really happy with it as well. I don't think we've ever had to wait more than 2 days. And labs, X-rays, getting referred out for allergy care in my son's case were all super easy and really probably easier than when we were in the health net system as well.
Great. Thanks, Grant. Appreciate you sharing your perspective. And Tanya, not to put you on the spot, I know I think Tanya might have to drop off. I was trying to see oh, she's on still. Any, curious as to see where the students and if there's educational material for that is being shared with med students around this, or is it something that they see later?
You know what? This is brand new information. This is not a model that we talk about with medical students. It's pretty wild, and I'm excited to hear about it. I,
Great. Thank you
Here,
for being on. You want to say say your role, Tanya, so folks know where you're coming from?
sure. Yeah, I'm a general internist at UC Davis and an associate dean in the School of Medicine.
Thanks for being on.
Yeah, this is great.
Hey Clay,
Love the connection. Yeah, please.
Clay, if you don't mind, I'd just like to chime in as well. I my daughter and I are part of Jeannine's practice, and from a patient perspective, I also have healthcare through we both have healthcare through Palo Alto Medical Foundation with our insurance. But the reason that I went to her practice and was looking for another option was because I have unique health challenges that I needed somebody to spend more time than just what was talked about, the 3 minutes with face to face to a doctor. And we've also had some similar challenges with my daughter. And what it means is it means access, and it's very simple. And it's streamlined from, you were asking, where do you get labs done? It just depends. You go through your insurance, or or Jeannine will, refer you out to get the labs done at one of the lab centers, like Quest or whatever in town. And it's very seamless. The insurance kicks in, there's a reason to have it as a patient, but at the same time, it's having the ability when I'm having an issue with my anaphylaxis, I have immediate access to a physician who can assist me, as opposed to, worrying about when that might happen. And so it's a great model. I'm eternally grateful for the model. I can see that it would be difficult for some physicians to transition into, but it's these kind of models that I think are going to make a huge difference for physicians practicing medicine and giving them ways to practice in meaningful ways, and then also for
Absolutely.
patients to have access in meaningful ways that they might need more of than the average patient who's relatively healthy all the time. So
Great. Thanks for sharing, Donna. That's super helpful as well. Yeah, this is really, as Tanya said, I'm the same way. It's like really soaking it up. I love every time I hear more about this model. Great. So we're right at time for questions. We have maybe one more. John, you got anything else? And Don's been quiet. Don, are you with us still?
Yeah, I'm still here. I'm just listening, taking it all in.
You're welcome to comment if you have any. I always love hearing
No,
your
it's this
comments on these
is
things.
this is a great alternative for a lot of individuals. This is really interesting, especially the surgical side of this. And Jannine's been indoctrinating me as for a while. So, um, yeah, it all sounds great. Thank you, guys.
Thanks, Don. All right, John, you're open for another one if you have a couple, if you have one, and then we'll go to Amy.
I guess I would just say one thing here. Tia, write a book. Um,
Yeah, exactly.
Direct primary care is easy. What you're doing is way cool. All kinds of, critical thinking involved. But there's an algorithmic model. I don't know if you played with AI with this, but that'd be pretty interesting to see what kind of solutions it could provide. All you have to do is frame the question. If you frame the right question, you're going to get an amazing answer. I can guarantee you that.
I plan on having a
So,
memoir coming to you shortly. And I wanted to
okay.
add one more
Awesome.
thing. This is not limited to medical care. There is surgery centers that are very cash friendly. They make it easy for patients to get their surgeries, to get in and get out. And in some instances, people can use their insurance to get their facility covered, their anesthesia covered, and then the surgeon can discount their rates in order for the patient to get what they need to get. So that is a fun field for me to see if we can get surgery centers more involved to get patients the surgical access as well. So thanks so much for having me.
Awesome. That's great. Okay, moving on to our next speaker. So we've kind of had a primary care specialty and back to primary care, a different perspective. Amy, you want to jump in and introduce yourself? And thank you for joining. I know you're traveling this week and appreciate you being here.
Yes, and sorry, I just switched to my phone because I don't know, my
Oh, I just saw your
computer's
text.
plugged.
Sorry.
Yeah, my computer's plugged in, but this outlet here isn't working or something. So yes, hi, I'm Amy McEntee. I know several of you. Um, I feel like I'm the opposite of DPC. Um, I have worked in community health since I finished residency. My first job was at the San Benito Health Foundation in Hollister for like a year and a half, and then I was at Salud para la Gente for, oh gosh, I don't know, I think 16 years, and was the CMO there for 12. And then about 2 years ago, I moved over to the county of Santa Cruz, and I'm the medical director at the county clinic there. When Clay asked me to talk about this, I just kind of jotted down notes on things related to access, divided up just from perspectives like on demand challenges, clinical challenges, and I think it might be easiest to just go through that. And I think there's nothing that's surprising to anybody really either. But just for reference, or just to start, like on the demand side of things, this past year at the county, I think it was like in November or December, when we started the push to try to expedite getting all of our new patients who'd been assigned to us into the clinic. There was 2,000 patients who needed to get in, and they're all supposed to get in within 120 days. And I believe we only had like 3 providers with open panels. Everybody else was pretty much at capacity. But we've been slowly chipping away at that and set up some systems to try to get people in quicker so that at least they could get their foot in the door and have a home in a medical home somewhere. So if acute things came up, we'd be able to address it quicker. And I'll talk a little bit about that. For a while, the other community health centers in town were closed to new patients because they were all at their capacity. So the county doesn't typically ever close their doors, even if everybody's at capacity, just because it's, I think, charged with taking care of everybody. And is oftentimes it's hard for, as everyone knows, people who have Medicare only or Medi-Medi to find primary care somewhere. And so they're often coming to us. I would say also, since I've been at the county, that the complexity of the patients is pretty high. I did residency in a county system, and I feel like I'm back to residency days. It's a lot of my day looks like heart failure, renal failure, liver failure, diabetes, hypertension. But everybody's pretty sick. Not everyone, but a lot, a larger percentage than what I had when I was at Salud. And the county takes, all the uninsured patients as well as other places. But we have a decent number of that. Some of the challenges that most places have, and that the county definitely experiences too, as well as other community health centers I've been at, is just space, recruiting new providers, and then when you do have new providers and you have this complex medical situations as well as social situations, being able to provide enough support for new grad physicians as well as like new grad advanced practice clinicians who we have, so that everybody's always a little bit has a baseline overwhelm, I think, and being able to support them so that they can be successful. And then, as always, the budget constraints. Right now, one of the budget issues that many community health centers are thinking of are the anticipation in having a lot more uninsured patients in the coming years. We haven't seen a big hit of that just yet, but I think it's kind of a slow roll. And we will be seeing that over the next year or two. With me, when I think about that, when I started in medicine, it was in a community health center prior to ACA. And the way we practiced medicine was so different then. It was on a paper chart. There wasn't the metrics. And I would see 30 to 40 patients a day. And not that that was enjoyable necessarily, but it was pretty common. And that's hard to do on an EHR, and with everything like for a new patient intake, all of the stuff that has to be addressed with the ACEs, the different depression screenings, the drug and alcohol screenings, all of that intake work is probably about 20 minutes. And then you have to get to the rest of the health history and all of that. The other thing with going to more uninsured is that a lot of people who've trained more recently haven't really trained in environments without being able to send patients to specialty care. Or one of the other things that I've been thinking of is that when I first came out of residency, for patients with Medi-Cal, it was really, really hard to get psychiatry or behavioral health. And that was something that came from ACA with more coverage in that area. So prior to ACA, as a primary care physician, I did a lot more of the psychiatric medications and such and got comfortable with that. Um, People who've trained since the ACA, what I've noticed in our clinic is they're not as comfortable with some of those things. And I think a lot of the primary care working in community health centers are going to be pushed to dig deep and to do some of these things that they haven't had to do for a while because more people have been insured. When I first came out, I think the clinics I worked at had, 30 to 35% of the clinic was uninsured. So you had to do a lot more with for the patients, but that the training's a bit is different now, and the way of providing care is different. Um, so I think those are, I think some of the things, and one of the things that I frequently talk with providers is, with concerns about not having enough time for things or not being able to do this, and it's true, and it's also hard to balance this scaling of we need to be able to not have burnt out providers, be able to provide high quality care. And we're balancing that with the demand that's in the community where there's, a lot of, we have 2,000 people on the waiting list just waiting to get in. Some of the things that I would say that we've done that have been helpful is we hired a new provider who is primarily a same day provider, and she does do some new patient intakes every day. And then once she gets them intaked, tries to assign them to an appropriate PCP. But at least at that point we have them in our system. And if something comes up with the ER, or they have an acute need or something like that, it's easier to get them back in because they've already have established in our clinic. We have been utilizing more telehealth because of the space constraints, and that's been helpful as well. It is, a culture shift for people who haven't been used to that. And things that I have found helpful in other locations for working in this type of a setting are at Salud, it's had care coordinator positions. And so these were MAs who had been trained in doing like all of the prior authorizations, all of the paperwork, all of the DME, all of that sort of thing. So they would take care of all of that and bring it to us ready to just sign off, and it made it a lot easier. We also had two providers that supported the clinicians who remotely who were in clinic seeing patients and managed the inbox in basket all day for providers who were seeing patients. These providers that were remote were doing all of the phone calls that came in while you were with patients or your refills or things like that so that you could really just focus on the patient in front of you. I found that really helpful. And being at Salud, there is a community health support services that are in-house that take care of kind of all the social needs of the patient. So that kind of takes it out of the visit. But one of the things that I've noticed too, as there's been more of a move for addressing social determinants of health, which I think is great and that definitely impacts a person's health. And some of the systems that have been set up require a fair amount of involvement from the primary care, which I always find a little bit strange. Like right now, for example, in my clinic, we have 600 patients who are part of the food box program from the Alliance, which is good. They're able to get more nutritious food. People have really enjoyed this. They're like, oh, I'm eating more fruits and vegetables because they get sent to my house now. But in order to get that benefit, they need a letter from their primary care doctor explaining why they should qualify for this. And to me, it seems like you should be able to look at the claims data and see like, okay, this person has diabetes, they have hypertension. Clearly, they're going to benefit from supplemental nutrition. So things like that, where there's been a push to address social determinants of health in healthcare. And I don't always understand why it needs to go through the primary care provider. I think there's a lot of people who could look at those things that are not physicians that could take that off of our plate. And it'd be nice to look at those types of things. So that's everything that I had
That's
prepared.
perfect, Amy. You knocked it out of the park while traveling and remote on your phone. It's like, of course you did. Thank you so much. That was super, super it's interesting. Questions for Amy for the next 9 to 10 minutes?
Amy, this is John. First of all, the work you're doing is absolutely amazing. It inspires all of us. Yesterday at Dominican's Ethics Committee meeting, we reviewed an article on inequitable access to care uh, within ethics on the ethics committee, and very quickly, this there's no way that this doesn't morph into questions of civic virtue, and ultimately it morphs into kind of the biological determinants of morality. And so the work you're doing is so amazing, but I think we need to go back and look at universal, access to care, universal coverage. The CMA has been involved in that for years, but it seems to have fallen by the wayside, for a number of political reasons. But what you're doing is absolutely amazing, and it's the greatest service. As we reviewed this in the ethics committee, which is really where this I think really should land. We looked at the ridiculous top to bottom income disparities around Homo sapiens on the planet, and if you want to look at an interesting place, that's an interesting place to look. So I just thank you for the work that you're doing. It's the deepest work of all.
Thanks, John.
Thank you.
Well, we have other questions on the phone. That was a really good discussion, and thus far we have a few more minutes for Q&A. Oh, Donna, you mentioned, Amy, what's the percentage of patients that get telehealth in your practice?
Since I've been at the county wasn't doing a lot of telehealth previously. And I came from a clinic where about 25% of, during the pandemic, Salud switched family practice to about 25% of their visits were telehealth. And really that was, the clinic had expanded during the pandemic. Like, we hired a lot of providers, and there was a lot of demand. There was no way you could have fit everybody back into the building that had been hired. And so it worked well that way. And it's, there's a lot less overhead and all of that. And the patients really liked it too. There was, many stories of farm workers not having to take the day off of work and being able to, do their telehealth visit on a break at work, which is super helpful and financially better for them. And just the whole thing worked. So it's newer at the county. And I would say that it's less than 10%. It's I think whenever you bring in telehealth, especially we have a lot of older patients, it's a new concept. And people like it once they're used to it, but it's culturally different for the patients. It's also for the staff. Like, it's taken a while for staff to get used to, like, oh no, that person's not on vacation, they're just working remote, but they're actually really busy while they're working remote. So it's been a culture shift, and it's only about 10% right now.
Great, thank you. I like that example of not having to take the day off work for the farm workers. That's really, really cool. Okay, so seeing no further questions for Amy, we'll let her off the hook. And then I just want to shift back, just kind of loop back to our initial topic from earlier in the day. Dr. Flores, are you still on?
Yes, I'm here.
Great. Hi, how's it going? Nice to meet you virtually. I work with Dr. Flores' partner, Blair Cushing, and here at the hospital. She does nights for us still. So we talked the other day, and I'm glad she was able to invite you. Can you just introduce yourself to the group and talk a little bit about your practice, and then we'll have more Q&A, and then we'll probably end early.
All right. So hi, everyone. I am Jacqueline Flores. I'm an MD trained in family medicine physician, and I am opening up a practice, actually, a DPC practice here soon with Dr. Blair Cushing in Monterey, California. So we chose Monterey just because that's where we were able to find a place to practice to open up our new DPC clinic. Really excited about that. the experience has been, a whirlwind of difference of training in a traditional, fee for service model with training, and then learning how to run a business now, basically, is what I'm at. And I chose to, take on this endeavor with Dr. Cushing because, similar with like Dr. Nguyen, after having a family, I needed a little bit more time with my children, and realizing that I'm not going to be able to maybe continue to do the traditional practice that I thought I was going to do for the rest of my life. I thought that, venturing off and doing a business venture, and opening up a clinic and starting from zero, is going to be a couple of years, before we're up and fully, running and everything. But I decided this is what I needed to do. It was time for a change for my family and I. And that's what we're going to be doing. Come here soon.
Wow. Great. Well, all the best, and I would love to hear more, and maybe have you back on here as one of the panelists in the future.
Yeah.
Questions for anyone on the panel or Dr. Flores?
Where are you in Monterey?
So we're going to be right on El Dorado and Cass, where all the other
Oh, yeah.
doctors, chiropractors, dentists. We were able to find a location there on El Dorado Street, actually. So,
What are you doing for marketing? What's working for you, or what do you need help with? How can we help?
oh, that'd be
Mhm.
great. Yeah, thank you so much. Yeah, so we are going to be doing some marketing here coming up soon. One of the big things is we're doing like the word of mouth thing, or when spreading promotional materials amongst like families and like other people that know us. Like people that connect other people. There will be soon here. Basically like the Instagram, the Facebook, the social media, those types of things, like getting so that people can find us, trying to get our Google Maps going, right, with the location,
Mhm.
so it's people can actually find us. So it is spreading, the word to get us out there. Yeah, I'd like to maybe chat offline with you, T, of how, things that
Yeah.
worked for you. I have your email, wrote it down.
We'll do happy hour. Happy to do it.
Yeah, yeah. Because sorry, just I didn't really get the chance. And you're in Santa Cruz or where?
In Aptos in Santa Cruz.
Aptos. Okay,
Yeah. Uh-huh.
wonderful.
Well, this is exactly what we were hoping these series would be. I know it's not a lot, but 20 people tonight. But I think everyone
Yeah.
that's here wants to hear and wants to learn. Um, the one thing I'll do, oh, Donna, you have a question? And then back to John.
Yes,
Go
I
first.
wanted to ask of Amy, in general, um, what do you think? There's going to be many challenges with respect to providing care to all the patients that we anticipate are going to need care because of HR1. And so my question is, what is it that if you were going to pick the top three things that organized medicine can do to help physicians um, meet the need that is currently happening and the need that's going to grow, as well as also help the patients get the care they need in a timely manner, particularly within the structure that you're in. What would you say those top three things are, if you can think of them off the top of your head right now?
Good question. You're the moderator now, Donna.
Um, hmm. I'm not totally sure, but one thing that really comes to mind is that I think support from specialty, because I think more newly trained people have been used to having more specialty access for their patients, and it's really hard for uninsured patients to have specialty access. So you need to push yourself to do more as primary care when you have an uninsured patient, and that's very uncomfortable at times. So I I would I've always thought it would be really great to have a local like annual specialty CME type of thing where it was for supporting the community health providers, because we don't that's I think a big thing that you miss out of when you're in community health is that you're not side by side with the specialist. I think sometimes we're referring things where you're like, oh gosh, I know that there's more I could do here, and I'm way behind, and
I have the ability to send them on. So I think that's one area. I don't know how that relates to organized medicine supporting that.
That's a great
Yeah, and
idea.
there's kind of specific specialties too. I guess this is not to be like I'm not trying to be negative or whatever. I'm trying to be eloquent, but one thing that I find challenging, in recent years is pain management. We're definitely like have gone down with using opiates and things like that, and I think this ends up in community health quite a bit. And pain management as a field really now is more procedures based. And oftentimes we inherit patients who are on all sorts of meds that, we wouldn't have started, or we maybe don't want to continue. And we're coming up with trying to figure out a taper plan and stuff like that. And I would really love to see some support in that for primary care in general, and really primary care in the community health setting.
Right.
Great
Those are
answers.
both great comments. Thank you, Amy.
Thank you both. Grant, you're next.
So for those of you involved in direct primary care, we're going to have medical students down here on the Central Coast in the next couple of years. And I guess, what would you like us to be telling them?
Well, I think actually from an education standpoint, we are having more DPC docs go into the medical school and the residencies to talk about the model. We're having them actually show up at some of our, there's the DPC Summit that's put on by the American Academy of Family Physicians in Kansas City usually. Oh, no, I think they're going to be in New Orleans this year. Where we see the residents and med students show up, and where you have this actually incredible commingling of practices like ours, people just starting, people in their first year, second year, looking at the model. And there's a great networking effort of communication and connection. I think one of the things about this model is that most people, while occasionally you'll see somebody who wants to be the consultant to help set it up for you and then also extract money from you, most of us are actually very open for people who are interested to come, and whether that's talking on campus or coming for a morning so I can explain what the model is. Because there is that big educational hurdle that people are going, I have this insurance card and you're not taking it, and what's going on here. So we're sort of slowly working on growing because we do think from a model perspective, it's hard to recruit from the established people at the moment. We know we capture, there's even some data that's shown that when you expose medical students to the model who haven't yet picked where they want to go, they're not going to be the surgeons, they've not going to be the specialty that they've already decided on. But when they see our model, that's in sort of in contrast to what they experience in their training from family medicine primary care, that suddenly the light bulb goes on and they actually do increase their selection for primary care with that exposure. So understanding and knowing that because they all see the burnout thing, and we don't help ourselves when we have 4,000 patients and 30 patients a day, and really nobody's getting the care that they really need, and the relationships aren't there, and people are being bounced in the big groups amongst other doctors, and they start over, and that continuity is gone. So they came into medicine wanting to help people, help the community, and they're seeing where what should be the focus of care and primary care and the support that really primary care needs. We have to go back to that. We have to go back to first access. We have to go back to reasonable time continuity and the commitment for us as primary care physicians to do full spectrum primary care medicine. So wherever we can kind of get the exposure, actually in my new building, I'm getting a section where we have kind of a conference table. So
Great.
we can bring people in, but it's important. Our movement has kind of been the grassroots movement of the docs who are like, I can't do this anymore. I got to go do something else. And what we're now seeing is, what we need to fundamentally do is shift it to this is the better model. This is how we support primary care. This is where we need more clinicians, physicians to come into primary care and do this work. Because we know you had the commitment when you started medical school,
Mm-hmm.
but it gets burned out of you by the time you make your residency choice. Um, there's actually, if you've ever heard Renee Critchlow talk, some of you may have seen her at some of the academy meetings. She is the executive, I think she's what is she? She's the chief medical officer of one of the health centers, and is one of the School of Public Health at Harvard professors. And the last Academy meeting, she was in the AI computer model, and she's the progressive kind of in this whole model. So she's the person who came into her clinic and said, pediatricians, family docs, internists, they all should be paid the same. They're all primary care. Start there. And got everybody on the same plane and, started kind of working through better systems in the clinic that she became a part of. But one of the things that she keeps pointing out is that the advances in technology are beginning to move these procedures. So, for example, at the Academy meeting, people had, you can buy the eye thing to look at the back of the eye, take the picture with the iPhone, and you've got it, right? And then you can send that to the ophthalmologist, and you don't have to send somebody there and say, this is fine, or have them look at it, use the AI programs to do that. She says you got to look at how all of this is going to come back to the primary care physician. We're going to need the specialists for more advanced things that and some of these simpler things in terms of technology are going to come back to us. And she kept using the Star Trek example. There was always one doctor there. There's all this technology,
That's great.
doctor there. Family doc was there. So, I think this idea of kind of, I think we're going to start retracting actually. I really, while we've all used specialty care and we rely on our colleagues to get certain things done, and we're going to start seeing where that's going to be pushed back into our world, our purview. And so we're going to have to learn to deal with some of that. There are some people in family medicine who are gung-ho, I do everything, rural clinic, I'm going to deliver babies. And there are some family docs who are like, no, I'm just doing the easy primary care stuff and send it on. I think the system has geared them to do that.
Yep.
I think the system collapsing is going to push it back at us.
Great discussion points. Thank you for those. That's really helpful. Um, Gosh, so Jamie had to jump. She's got mom duties in Vegas for her daughter's event, so I think she took off already. We're probably going to end a little bit early, but I just wanted to clarify. Don, can you summarize what you think Amy's suggestion was? Are you still on? I just want to figure out what the takeaway point is for that. I'm trying to capture for our notes next steps, but we can follow up later, Don.
Yeah, he's still on the call. He's just not talking.
Yes, I'll talk it. Okay, well, any other questions before we either circle back to Don or take off here in a few minutes?
So Clay, this is
Yeah.
both to Jeannine, who's doing inpatient care, and to Jacqueline, who's on the cusp of the process. How do you see transitions between hospital admissions, and back to your practice as being better facilitated? In other words, a cadre of hospitalists. When Sri was working at Dominican, she was kind of doing that. There's always been, I think, a significant communication gap, or a potential communication gap, in this process. So could you speak to that? Both of you.
Yeah,
Jeannine, you're doing it,
we're still
and
doing it.
Jacqueline's about to. I'm curious how she's going to handle it.
Yeah. We go through these discussions because we are the rarer version of DPC that continues with hospital care, especially in a suburban setting. Um, and we kind of go through the, if we just cut that off, let somebody else do that, it wouldn't be as big of a headache. But then we run into the situations where if if they didn't, if the specialist didn't know what we knew going into it over the continuity and things that have been done, the workup, and not start from scratch, the errors go down. The they're just, I mean, even when I call the ER and say, hey, we're sending somebody over, this is this, we're watching in the background. If the labs come in and, I know things stall out there, I can call in and say, hey, I see all the labs are done, I'll see them tomorrow morning. You get the time, move them out of there, and can help facilitate that transition. And then I know what meds I've used in the hospital setting. I know what meds the patient's using in the outpatient clinic. And that medication discrepancy that goes on can be horrific. I've had a situation where someone was brought in from a skilled facility, and a few years ago, somebody just dumped the SureScripts
Mm.
list of the 6 medicines that I had taken away over the last 6 months in this patient.
Yep.
And fortunately, I caught wind of it early enough to get in there to stop it, do the order, stop it, and then take over care. Um, but it's, the communication barriers between primary care and the outpatient world and transitioning back have been a problem
Mm.
for a number of decades. Those of us who were still doing our work, who could at least see what was happening and where it was going, everybody stepping out of that has put up the silo, and that's been a serious problem for errors.
Yeah, that's
Any
music to my ears,
emerging
Jeannine.
best practices?
Pardon?
Are there any emerging best practices
For transition?
for this problem? And this med reconciliation is number one cause
Yeah.
of
Yep.
harm,
Yeah.
but just in general,
Well,
um,
I think, there's resistance on both sides to talking to the primary care doc. Sometimes it's like you guys deal with it. I've seen it. We want to know because we've invested in the patient. We know the patient, we know their family, we've got the trust, we want to know what's going on. And that's part of our continuing to be committed to doing this. And so that we can kind of pull it, stop things when they're inappropriate, explain that no, we're not doing this, we're going this way. We are being there. I mean, that's part of the calling the primary care doc and being committed to doing that, encouraging social visits, and paying for those. If you're in a fee-for-service world, the primary care doc has been totally isolated from the hospital setting, unless they make that effort or commitment to be a part of that side of the silo.
Hmm.
So where that communication has really often not been ever since we've had the development of the sort of hospital silo that's occurred, that's been a chronic problem. So, if there were ways that we could, I've always thought in residency, you know, making it so that docs had to talk to each other.
Hmm.
Even though, you were a resident and there's an outpatient physician out there, but, you didn't pick the phone up, and, making a part of that process is critical, and it just has never happened.
Great points.
Mhm.
Yeah, medrec is a huge risk every time you change setting.
Yeah.
Um, Great. So, shout out to all three of you. This has been exactly what we were hoping for, getting people together, learning from each other, and building on momentum. Our next panel will be on May 20th. And then again, Don, if you can talk, feel free to jump in. Don and I are kind of brainstorming offline a little bit about what that looks like. It'll be the first part on access, or sorry, advocacy. And we're gonna make advocacy cool, aren't we, Don? So
Yeah,
do you
in this world.
do you have some
Um,
ideas about how you, I'm just, while we have a few minutes, I will brainstorm with you offline as well, but I was thinking panel one was like we're talking about you, maybe Dr. Spiritos and maybe Kira, and then panel
sure.
two, and just try to figure out how to get little bites out to people. So whether you're educator, student, or in our roles, why does it matter? And why do we want you to be involved?
Well, the answer that is simple as everything we've heard tonight is the economics of the healthcare system are in shambles. And it's the patients that suffer, it's the practices that suffer, it's their challenges. And then that all comes down to political choices. Often you hear people talk about the social determinants of health, which I think is somewhat of a misnomer. I would venture to say that I think more of these are the political determinants of health, because a lot of this has been done by choice, by political choice, 40 years ago, 30 years ago, 20 years ago, 10 years ago. And we're seeing the effect of the political choices that were made um, back on July 4th. So understanding those prevailing winds and how we can influence that to benefit our patients and communities, I think is always important. And just having a broader understanding of what the healthcare landscape looks like in the macro. So yeah, more to follow.
Great. I know I'm going up tomorrow to Sacramento for the Council on Legislation. And for those of you that might know, you get this 400 or maybe it's 200 pages of legislation, and I'm about halfway through it, and it's my head swimming. And I've become pretty indoctrinated to these meetings and how tedious they can get, but just to make it manageable is so hard.
Mhm.
Any of
Yeah.
it.
Yes.
Yeah, it's a lot, but that's the point. We talk about having influence with our local electeds, and we really should lean in on that. Don Addis is, the chair of Assembly Health, and so having that person as a resource and an individual that we can talk to really helps move the needle in terms of things we can uh, talk to her about in terms of stabilizing um, medical practices, scope questions,
Mm,
um, prior authorization issues, check many boxes. There's avenues for improvement and continued engagement that really help us do the things that we tend to do outside of the office.
great. Well, we'll use your voice on the 20th, and then we'll brainstorm on what the next one will look like in July. And if you want to invite anyone you want to invite, and I can encourage you all to invite your friends. I think 30, 40 people is about right for this type of group. And I've
Mhm.
learned a lot tonight. Anything for anyone with closing before we close?
Before you leave the topic of the planning for the next speaker series on advocacy, it was brought to my attention today about Donna Addis's interest in understanding more of the impacts of environmental health, particularly as
Mm,
events happen like what happened in Moss Landing
mm,
and the long-term effects of that. She's very interested in gaining more information and would like to have open dialogues with physicians. And so perhaps part of our process might be to consider bringing individuals in like Dawn and having an open dialogue opportunity with a group of physicians. And so anyway, just something to
yeah.
throw out there.
Yeah, let's talk more tomorrow or even text, but we can see if she's available on the 20th or our July date, and then build a panel with Don Hernandez around
Yeah,
that with her.
yeah, yeah.
Love it. This is how things happen. You open the door and get in the room and open another door, right?
Mhm.
Good. Well, you all, I really appreciate your time, and we're about 10 minutes before the hour, but I think we can let everybody go unless there's any other burning discussions.
Now, I want to say thank you to everybody for putting this on and allowing us to present the model. And I want to say good luck to Jacqueline and Blair. I see Blair snuck on there.
Oh, hey Blair.
Mhm.
And if you
Mhm.
have, and actually, I would like to know, are you guys going to do hospital work too? Or are you doing that, Blair, as the background, like you're doing the hospital stuff in addition?
I do not
Okay.
plan to do hospice work at this point. Yeah.
Okay. I was just
Mhm.
curious.
I
But if
think
you guys
Blair's
need
in the
anything, feel
airport
free.
commuting somewhere. So thanks for
Yeah.
joining,
Yes,
Blair.
I am. I'm like about to get on an airplane, but yeah, I am intending to continue doing hospitalist shifts, and that's even like once I ramp up to what I believe is going to be my full schedule at the practice, because I do think it's important. Like you guys were talking about the transitions of care. To me, I feel like that's just part of being a true full spectrum family physician. I'm not trying to give up that piece of my practice.
Good.
Awesome. And then Blair, this was recorded, so you'll be able to hear what Jeannine's experience was at the beginning of the call. I think I really appreciated it. I know you guys know each other, but
But yeah, Claire's been an advocate for DPC for some time. She was involved in the Texas Medical Association and helping promote the model. So
oh, well.
I'm happy she's finally settling into a DPC practice.
I needed Jackie to come with me, honestly.
I know you
That
need
was
a
the biggest thing
partner.
is I was like, I've wanted to do this for like a decade. So
I know.
I mean, honestly, even before I started residency, because it had already, caught on in Texas in a certain way. But trying to figure out how to do it alone and also really do the full spectrum and do hospitalist work and do these other things that I didn't want to give up, felt like really impossible without a partner. So Jackie kind of showed up at the right time.
Great. Good luck if you need
Awesome.
anything. Call
Awesome.
us.
Oh, this is perfect. Well, thank you guys so much. Hope everyone has a great rest of their evening, and we'll talk again in a few months.
Thank you. Take
Thank you
care.
all. Take care. Bye. Thanks again, T.
Thanks,
Thanks, Steve.
everybody.
Bye.
Good night.